Why am I here? Fractures are sentinel events, right? Just the same way as an MI gets you to a cardiologist, a fracture should get you to somebody who does metabolic bone disease, and it doesn't. So this is part of the AOA's Own the Bone strategy, whereby we're asking orthopedic surgeons to own the bone. These are centers of excellence for Own the Bone in India, so congratulations to those of you from there. And the second part of this international movement is, pre-operative bone health and post-operative bone health. So I'll talk about the complications later in the talk, but when I see a patient post-op, the way that I explain it to them is like the Leaning Tower of Pisa. You can have the best architects in the world, and if the foundation is poor, it's not going to go to plan. So it's not your surgery, it's their bone. So osteoporosis, I'm obligated as a metabolic bone doctor to show this slide. It's a disease characterized by low bone mass and or microarchitectural deterioration. Sometimes the bone mass is normal, but the bone quality is poor. And your intraoperative assessment of the bone density and the bone quality is actually really helpful for me. Very often I get an email, the bone was like Swiss cheese when I was in there. And that's meaningful to me, and we know that that's meaningful from ongoing studies and data. So I had to learn something completely new, which is osteoporosis in India. The prevalence of osteoporosis in India, these are just estimates. 20% of women over 50, although in older ages it's as high as 64%. And with considerable presentation in men too. And I think men get ignored in terms of metabolic bone. The risks are increased with urbanization. There is an earlier average age of menopause here in India, almost 5 years earlier than in the US. The peak bone mass, which is kind of set in stone by the time you're 18, is actually lower than the Caucasian-based databases which we used for our T-scores. And there are also polymorphisms in D receptors that may be contributing to the risks here. The hip fractures per year estimate is close to 500,000 with preponderance of females. And the risk of death after a hip fracture is actually higher than that after a myocardial infarction, at least in the US. Awareness of the condition is very low, only 10 to 15% of the population, and DEXAs are scarce. It is recommended that you have more than 10 per million, and here there's only 0.25. Even when diagnosed, very few are treated and very few stay on their medication. So these are the WHO definitions of normal bone density, low bone density, osteoporosis. Those are your T-scores that you get from a DEXA machine. But we call it established osteoporosis when a fracture has occurred. There's also a parameter called the trabecular bone score. I'm not sure of the availability here in India, but they are working on an Indian-specific database, so obviously it's up and coming. This tells us, this is a sort of a marker of bone quality, how well organized is the bone, and it's categorized as normal, partially degraded, or degraded, and that is an independent risk for fracture. And unlike bone mineral density, osteoarthritis and its severity do not impact the TPS, so extremely useful for orthopedic surgeons. And we also, it helps guide our treatment because anabolic agents show the most improvement in that trabecular bone score. The way I explain it to patients is that they can have a tight sweater or they can have a loose Afghan. There is something called the FRAX. This is country specific and can be calculated without the DEXA. So it's extremely useful when DEXA availability is low. The thresholds for treatment for that are more than 20% risk of a major osteoporotic fracture in the next 10 years, more than 3% of a hip fracture. It is an imperfect, because they have discrete yes, no answers for continuous variables. It is imperfect, but there's something called the FRAX Plus, which is $1 per use, very expensive, that can help refine this risk further. So actually a great research tool. And I think what's really important is that a lot of times people rely too much on the DEXA when they have the patient in front of them. So yes, you make the diagnosis of osteoporosis if the T-score at any one of the 4 WHO-approved sites is -2.5 or below, We can make the diagnosis of osteoporosis in somebody with low bone density if the FRAX hits those markers that I had just mentioned. But most important of all is fractures. If you have a hip fracture from a low energy fall, that's osteoporosis by definition. It's like saying the angiogram was good, but they had an MI. With low bone density, if there's a clinical, meaning a symptomatic vertebral fracture, a proximal humerus fracture, or a pelvic fracture, that we treat as osteoporosis. A morphometric vertebral fracture, meaning it's just found incidentally on a chest x-ray. You know, if he's a 18-year-old who had a diving injury, or he's 50, but at 18 he had a diving injury with back pain, and he has a morphometric vertebral fracture, you may not call that osteoporosis. But, you know, so you have to really get a sense of the patient if you do find one of these incidentally. With regards to the distal forearm, you know, if I were rollerblading in Central Park and I broke my wrist, probably not osteoporosis, but if somebody slips on one of these beautiful marble floors and breaks their wrist, probably osteoporosis. So you think about the mechanism of injury there. So what about you guys specifically? So this is, Barantz did a lot of work on osteoporosis and treatment of osteoporosis in orthopedic surgery patients. So, you know, you seem to be, you know, about 1/5 to 1/4 of patients that you're seeing have osteoporosis, and very few are treated pre-op. At least in this study, about only 5%. This is further sort of both concurrent data and larger data sets. Basically, the net is that there is a very high incidence of osteoporosis in your patient population, and a very low identification of screening. And there may be reasons as to why. Patients who you see are slightly heavier, and we always think of the osteoporotic lady as this little thin nothing, so maybe they don't get screened. Also, when you look at the x-rays, because of the sclerosis around the joint, it may not look like the bone is washed out that would normally prompt somebody to get a DEXA. So there are lots of reasons, but the reasons, you know, fall away when you actually look at the patient population that you're seeing. And there is an increase in both fragility fractures, which makes sense, and periprosthetic fractures in patients who are at high risk of osteoporosis. And what happens when we treat it? Well, this is a very interesting study, this one that was published in October, showing total joint cemented or uncemented, and it seems that in the knees, cemented knees in patients who are at high risk of osteoporosis have the floor and should be used, whereas in this study, cemented versus uncemented hips in patients who are at high risk of osteoporosis, no difference. So, you know, I feel like they're much more likely to cement the hips, at least at HSS, if the patient has osteoporosis, and that may not be necessary, and we may need to focus more on the knees. And then this looked at a series of patients treated versus not treated, and it does seem that treatment for osteoporosis, as we would expect, decreases the risk of the periprosthetic fracture. So, you know, good for your outcomes as well as mine. Okay. So now there's sort of the push towards bone health optimization, just the same way that we optimize patients who have diabetes before they get pregnant. We always say pregnancy in a diabetic patient is 12 months, not 9. So too is this sort of magical 3-month number to optimize bone health prior to orthopedic surgery. So you want to address vitamin D deficiency. For optimal vitamin D in the Indian population, it seems like 1,000 to 2,000 international units per day. Usually we use D3 in the States, but that's not vegetarian or vegan, so then D2 would be used. There is inadequate calcium intake widely in India, so you want to aim for, and you can actually aim a little lower here than we do in the States, but it's 600 to 100 milligrams of dietary calcium per day. You only supplement to make up the shortfall. And there are great online calculators that kind of help you figure out how much you're actually getting, because you also don't want to overdo it. Smoking and alcohol, not a big contributor here in India, so bravo for all of you. But we do counsel patients to stop smoking and limit alcohol. The sedentary lifestyle, you want to encourage exercise. I tell my patients, get sweaty more days of the week than not. You want to do some strength or resistance training, and balance exercises every day. So everybody should be brushing their teeth, standing on one leg every day. Work on your balance, it's an everyday proposition. And then there's also the fall risk. You know, it's if your vision is not well treated, even a 25 decibel rate of hearing loss will increase the risk of falls 3 times because we echolocate like bats. You want to make sure people are wearing the right shoes, that they use necessary assistive devices, and silly things like having a light to the bathroom at night decreases the risk of falls. So small things make big differences. We have 2 classes of medications for osteoporosis. We have the bone maintainers and the bone growers. There is a mixed agent that is available in the US, not here yet, but it will be coming, very interesting drug. There isn't a lot of data with estrogen and selective estrogen receptor modulators in the orthopedic population specifically, but I did want to mention with regards to peri-op medication, oftentimes people's hormone therapy or their SERMs are stopped pre-op because of the risk of DVT. Transdermal hormone therapy that does not pass through the liver and does not upregulate the clotting factors does not increase the risk of DVT. So you can reassure your patients. But anyways, back to these traditional osteoporosis medications. I know that many of you have heard about this drug holiday, specifically prompted by these atypical fractures, but it's only bisphosphonates that allow for drug holidays. No other medications allow for drug holidays. And in fact, if you stop Prolia, denosumab, abruptly and do not follow it up with another agent, patients will get multi-level vertebral fractures and very severe rebound bone loss. So the drugs highlighted here are the ones that are available in India. So teriparatide is kind of your one and done osteoanabolic agent. Forteo is the brand name. And you see that that's where we have the most robust fracture protection. And also when we use it on untreated bone, that's when we see the highest increases in bone density. So if and when available, you always want to start with the growers first and then go to the bone maintainers. Sort of second on the list is Prolia, denosumab. And as I mentioned, if access and or adherence is an issue, this is not a great drug because of the rebound fractures and bone loss. Zoledronic acid is reclassed, that's a once yearly IV. Although we can see persistent fracture or persistent bone turnover suppression for up to 5 years. So if you're seeing a patient that you know you're not going to see again and you want to sleep at night, that's really a great way to go. That's that yearly IV. And then there's the sort of gold standard alendronate Fosamax, much maligned unnecessarily, but it is really inferior to our other medications. So if you have the capability to give the more potent agents, that's always the best way to go. And what does that mean for arthroplasty patients? So we know the bisphosphonates prevent periprosthetic bone loss after knee and hip arthroplasty. And very interesting Korean registry data show lower revision rates in lower extremity arthroplasty in patients on bisphosphonates. Denosumab Prolia prevents periprosthetic bone mineral density loss. There appears to be decreased early implant migration. And a study that was just published, very interesting, it may reduce the risk of needing a TKA at all compared with patients on bisphosphonates. With our anabolic agents from animal studies, all 3 of our anabolic agents improve osseointegration. The human studies to date are only with teriparatide, that we have an ongoing study with abaloparatide at HSS, and according to Radius Health, abaloparatide is coming to India soon. But we do see that there's periprosthetic bone mineral density increase in patients who are on teriparatide. So what do? Bone health optimization in your patients 50 years or older who are undergoing orthopedic surgery. Now, these are the US guidelines. Get a DEXA, a female over 65, a male over 70. Here in India, a female over 60, a male over 65, because of that 5-year shift. If there's been a prior fracture, that's, should, tweak your brain to needing to have a DEXA pre-op. And a much lower threshold for fracs that you calculate of greater than 8.4% major osteoporotic fracture risk in the next 10 years. If any of those are positive, they get a DEXA. If not, proceed to surgery. If they get a DEXA and it looks good, no osteoporosis, proceed to surgery. If they do have osteoporosis, you go to bone health optimization with whatever medication is appropriate for the patient and available to you. And so essentially, just a different way of characterizing this, it's the patient is at low or intermediate risk. Make sure that they are calcium and D replete, and then surgery. If the osteoporosis is at high risk, you want to make sure that that osteoporosis is treated, or at least there's a pathway towards treatment, plus or minus surgical delay, depending on the surgery and the overall health of the patient. But if it's severe osteoporosis, so when the T-scores are -3 or below, if they've had fragility fractures, particularly within the last 2 years, because there's a newer concept called imminent fracture risk, whereby you're at higher risk of a fracture having had a recent fracture, or if the frax is greater than 30% major osteoporotic fracture, greater than 4.5% hip fracture, then you want to put the brakes on, get them an anabolic, 3-month delay, and then proceed with surgery. Thank you very much.